everyone. Myself, Dr. Pritesh Pawar, consultant interventional cardiologist at Yashodhara Super Speciality Hospital. Today, I will like to tell you something about latest updates in hypertension. As all of us know, hypertension is a silent killer. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular deaths, which affects 45% people in 40 to 69-year age group. Raised blood pressure is among the most important risk factor for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women from 29% and 28% respectively. Despite that, nearly half of the people with hypertension were unaware of the condition. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension, that is ISH, has released the 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource poor settings. Optimal care refers to evidence-based standard of care, whereas essential standard refers to minimum standard of care to allow specification of essential standards of care for low resource setting. ACC-AHA has released a scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among patients with low AS CVD risk. Stage 1 hypertension means blood pressure systolic 130 to 139 millimeters of mercury, diastolic 80 to 89 millimeters of mercury. Among low risk adults, that is with no ASCVD, that is atherosclerotic cardiovascular disease, or 10-year cardiovascular disease risk less than 10%, with stage 1 hypertension, management starts with non-pharmacological therapy. Lowering systolic blood pressure targets down to 110 millimeter of mercury range substantially reduced CV adverse events in step randomized trial, affirming the sprint findings for an older Chinese population. Among 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime BP measurement, the 2018 European guidelines on the management of arterial hypertension recommend that diagnosis of hypertension should not only be dependent on office BP measurement, but also on out of office measurements such as ABPM or home blood pressure monitoring, that is HBPM. 24-hour and nighttime BP measurements were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as most relevant measurements for estimating CV risk. For every 20 millimeters systolic and 10 millimeters diastolic increment of BP measured at night, the risk of mortality increased by 23% and risk of cardiovascular events increased by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines recommend 5 classes of antihypertensive drug. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to the therapy and BP control. Therefore, the 2018 European guideline recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an individual dual fixed dose combination of AC inhibitor or ARB plus CCB or diuretics. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, nighttime antihypertensive treatment was associated with significant reduction in endpoints, including death. Thank you all for your patient listening.